Hi, we are going to talk about the evolving role of biomarker testing in treatment and prognosis of advanced melanoma. I'm a professor in the departments of pathology and dermatology and section chief of dermatopathology in the University of Texas MD Anderson Cancer Center. The learning objectives of this talk are to identify available biomarker tests for diagnosis, prognosis, and prediction of response to therapy in patients with melanoma, and to discuss evolving concepts in appropriate biomarker testing for patients with melanoma. This is the outline of my presentation. I will start with a very brief review of advanced melanoma and then of the biomarkers that are clinically used for diagnosis, prognosis, and prediction to response to therapy. Melanoma is an aggressive tumor of melanocytes that arises from skin and other organs. The molecular mechanisms of malignant transformation in melanoma have been extensively studied in the last 2 decades or so. As you can see in the right panel, many different molecular pathways are involved in the progression from in situ to invasive and metastatic melanoma. These pathways, such as MAP kinase, PI3K, AKT, GNAQ, GNA11, and others, constitute the basis for development and application of biomarkers for diagnosis, prognosis, and prediction to therapy in melanoma. Advanced melanoma occurs when the tumor becomes invasive and acquires metastatic potential. Metastatic melanoma to regional lymph nodes defines stage 3 melanoma. As you can see in the left upper panel, the tumor cells many times are easily identified on H&E, especially when they show intracytoplasmic melanin. Fine needle aspiration specimens, such as the one on the left lower panel, are also useful for diagnosis of distant metastasis in cases of stage 4 melanoma. Various immunohistochemical studies can be used in these settings to confirm the diagnosis of melanoma, such as this one, the pan-melanocytic cocktail that in our institution is composed of MART1, HMB45, and tyrosinase, as you can see in the images of the right column. Many different techniques aim to reveal the status of proteins, genes, transcripts, etc. are available to help the pathologist make a correct diagnosis of melanoma. Here is a list of some of them, many of routine use in our pathology labs, and many carrying not only diagnostic but also prognostic significance. Although some are mainly used in primary melanomas, they can also be applied to the evaluation of advanced melanoma. The immunohistochemical evaluation of the proliferation marker Ki67 and the double immune stain Ki67-MART1 has long been used as a helpful marker in the differential diagnosis of melanoma versus benign melanocytic lesions. In general, Ki67 proliferation index is increased in melanoma, contrary to what is seen in benign lesions. Digital image analysis methods have been reported in the last decade, proving very helpful and at least comparable, if not better, than manually performed Ki67 indices. Besides its utility in the diagnosis of melanoma, Ki67 and phosphohistone H3, PHH3, were studied in stage 1 and 2 melanomas, as you can see on the right panel, and proved to be independent prognostic factors, superior to mitotic counts by H&E. Loss of P16 was identified several years ago as involved in invasion in melanoma. The typical immunohistochemical expression of P16 is nuclear and cytoplasmic, as you can see in the upper right panel, in a so-called checkerboard pattern of expression. Complete loss of expression of P16 in the lower panel is suggestive of melanoma and useful in the differential diagnosis of spheroid lesions. A relative limitation in the use of P16 is the lack of published validation cohorts so its accuracy and reliability is unclear in the daily practice. P16, located on 9p21, is one of the probes tested in the commercially available FISH test for melanoma. Homozygous deletion of P16 by FISH, which may be associated with loss of expression of P16 by immunohistochemistry, favors a diagnosis of Spitz melanoma over Spitz nevus. In the right panel, you can see complete loss of the two signals in the nuclei of this spitzoid melanoma, indicating homozygous deletion. Internal controls, indicated by the arrows, exhibit intact two signals. The other three probes utilized in the melanoma FISH test are RREB1, cyclin D1, and MYC, for which amplification of signals is investigated, and if present, supportive of melanoma. PRAME, preferentially expressed antigen of melanoma, was identified as a cancer antigen recognized by cytotoxic T cells in melanoma cell lines. It is expressed in both primary and metastatic melanoma, but it is not lineage-specific, so it can be detected in other malignant tumors. In diagnosis, as you can see in the right panel, it can distinguish melanoma in situ, for example, being positive on top, from nevus negative in the bottom, and the cutoff that is usually used is 75% of cells showing nuclear expression. The immunohistochemical expression of PRAME has been shown to have a high concordance with genetic studies, as you can see in the left panel, that is estimated as around 90%. PRAME is also an independent marker of prognosis in uveal and likely mucosal melanoma, and interestingly, PRAME is also a target candidate for immunotherapy. Comparative genomic hybridization, CGH, evaluates gains and losses in the entire chromosomes, in contrast to FISH that targets specific genes. This technique is based on the fact that melanomas have numerous copy number abnormalities, or CNAs, in contrast to nevi. These chromosomal aberrations are found in more than 95% of cases and include several gains and losses, such as you can see in the left panel on 6p and 6q, for example. A more recent variation shown in the right panel is the single nucleotide polymorphism, or SNP arrays, that can detect loss of heterozygosity in addition to CNAs. On the right panel, again, you can see an example of melanoma on the upper figure showing numerous gains and losses of segments of chromosomes, while the nevus at the bottom lacks these abnormalities. Nevi other than Spitz nevi, which may show gains in 11p or 7q, rarely show chromosomal aberrations, while only rare melanomas fail to demonstrate chromosomal aberrations with CGH. Gene expression profile tests utilize RNA extracted from tissue and then transcribed into cDNA, so a gene expression signature is detected using quantitative real-time PCR. There are commercially available tests. One of these evaluates 23 genes that are differentially expressed in benign and malignant lesions. Notice that PRAME on the left panel is included in this signature. The expression levels are analyzed using an algorithm and then translated into score, where positive values indicate melanoma and negative ones support a benign lesion. The reported sensitivity and specificity scores are high, around 90 to 95% for both. Next-generation sequencing studies can be very helpful in the diagnosis of subtypes of melanoma and melanocytic lesions, and these include demonstration of HRAS mutations, for example, various rearrangements in Spitz tumors, or GNAQ and GNA11 mutations in blue nevi and blue nevus-like melanomas, and melanomas arising in the central nervous system and uveal tract. Melanocytomas can also be better defined by demonstration of mutations or loss of function of genes such as beta-catenin, BAB1, or Parker1A. You can see here in the right panel that adding molecular results to the traditional tools used in the diagnosis of melanoma can greatly improve diagnosis and classification of these lesions. This is a summary of the biomarkers currently used for diagnosis of melanoma. In our routine practice, we use these tests in selected cases only, where there is considerable difficulty in the diagnosis even after evaluating immunohistochemical stains. FISH can be useful when there is not much tissue available for testing through CGH, for example. Third promoter mutations are also helpful in diagnosis and will be discussed later. And regarding imaging and mass spectrometry, there is not currently commercially available test. The evaluation of traditional H&E preparations can give us considerable information about prognosis of melanoma. It is well known that a strong association exists between breast lobe thickness and ulceration and prognosis, and in fact, these features are the cornerstone of melanoma staging. Other biomarkers can be evaluated in tissues such as lymphovascular invasion or sentinel lymph node biopsy, while others require more sophisticated techniques or are even tested in blood. There are several melanoma biomarkers for prognosis. They can be related to the tumor itself or epigenetic phenomena or even circulating tumor products that many times are evaluated through liquid biopsies from peripheral blood. Third, promoter mutations were mentioned as useful for diagnosis since they appear to be frequent in melanoma, especially non-acral melanoma, and rare in nevi. Third promoter mutation is also a marker of prognosis and is associated with thicker lesions and reduced survival. In this study of spitzoid melanocytic lesions in children, only the tumors harboring third promoter mutations had fatal outcomes. Third promoter mutations were mentioned as useful for diagnosis since they appear to be frequent in melanoma, especially non-acral melanoma, and rare in nevi. Third promoter mutation is also a marker of prognosis and is associated with thicker lesions and reduced survival. In this study of spitzoid melanocytic lesions in children, only the tumors harboring third promoter mutations had fatal outcomes. Immunohistochemistry for TERT is available and appears to show some differences in expression in acral versus non-acral melanomas. However, the stain is somewhat difficult to interpret, as you can see here in the left panel, with some background and expression in normal structures. In addition, amplification of TERT, detected by FISH in the right panel, appears to be more frequent in acral melanomas, although non-acral melanomas may also show it, and seems to be involved in progression to metastasis and thus associated with bad prognosis. Epigenetic biomarkers include evaluation of abnormal DNA methylation in melanoma, a finding that is not detected in nevi, as you can see in the left panel. Aberrant DNA methylation disrupts expression of microRNA and contributes to a predominance of pro-tumorigenic microRNAs in melanoma. Abnormal DNA methylation in melanoma includes several genes, such as tumor suppressor genes like P16, that is hypermethylated in about 40 to 87% of melanomas, oncogenes, and many others. Aberrant DNA methylation in specific genes has been associated with prognosis in subtypes of melanoma, such as acral melanoma. Besides the histopathology and molecular-based biomarkers for prognosis already mentioned, some blood tests like LDH are routinely used by clinicians as indicators of prognosis. Status of BRAF, NRAS, and KIT mutations by NGS have been also associated with recurrence and overall survival. There is a gene expression profile test, which is different from the one used for diagnosis, that is commercially available in the US and is based on the analysis of 28 prognostic and 3 control genes. The results classify patients as low risk or class 1 and high risk or class 2 and may help with surgical management and adjuvant therapy. There is a similar aging panel used in Europe and another one that incorporates sentinel lymph node status for risk stratification. The list of prognostic biomarkers in melanoma is expanding as we speak. These are some of the tests proposed as indicator of prognosis. And this is the partial list of predictive biomarkers in melanoma. Several of these are the same proteins that are targeted by drugs, and others are related to tumor or tumor microenvironment characteristics. BRAF inhibitor therapy is indicated in tumors that show BRAF mutations, specifically BRAF V600E and V600K. The immunohistochemical expression of BRAF V600E, which is the most common BRAF mutation in melanoma, is highly specific and sensitive, and shows high correlation with BRAF mutational status by molecular testing. The interpretation is usually straightforward, with only very rare cases demonstrating equivocal or focal staining that require confirmation by molecular testing. This stain is reported as either positive or negative. There is no scoring system recommended. BRAF V600E by immunohistochemistry can be used for clinical decisions, especially in those situations where there is a critical ill patient or when molecular studies will not be feasible due to technical reasons or lack of adequate tissue for testing. In our institution, we follow reflex BRAF immunohistochemical testing as shown in the left panel in every newly diagnosed stage 3 melanoma patient, similar to what is shown in the algorithm. Clinicians can start making decisions about using BRAF inhibitors in these patients based on the immunohistochemical result. Confirmation by next-generation sequencing is recommended. Similar algorithms have been proposed for NRAS Q61R immunohistochemistry, as in the right panel. Indeed, the NRAS Q61R immunohistochemical study appears to be also highly specific and sensitive, and as BRAF V600E appears to correlate very well with mutational status, as you can see in the left panel. However, since NRAS inhibitors are not available for clinical use to date, NRAS immunohistochemistry is not widely available, and it's not a routine test in contrast to BRAF V600E. KIT, as opposed to BRAF and NRAS immunohistochemistry, shown in the right panel, is not specific, and tumors can express KIT in absence of actionable mutations. However, the use of KIT inhibitors in melanomas harboring KIT mutations have shown anecdotal good responses, and it can be an option for patients with these tumors. Loss of expression of PTEN, a tumor suppressor gene in the PI3K pathway, can activate AKT pathway and confer resistance to therapy in melanoma. Loss of PTEN has also been implicated in primary and acquired resistance to immune checkpoint inhibitor therapy. The pattern of expression of PTEN can be clonal, as you can see in the left and right panels, with striking differences in expression in different cell populations within the tumor. Immunotherapy using immune checkpoint inhibitors has revolutionized treatment of patients with advanced melanoma. Antibodies against both CTLA-4, discovered by our own Dr. Allison Nobel Prize in 2018, and PD-L1 are widely used in melanoma patients. As with biomarkers of prognosis, predictive biomarkers can be found and tested in tumor tissue, tumor microenvironment, peripheral blood, and even gut microbiota. Tumors with high mutational burden are associated with response to immunotherapy, along with those with certain genetic signatures such as interferon gamma-inducible factor. Favorable gut microbiome is associated with response to immune checkpoint inhibitor therapy. Combination immunotherapy using nivolumab anti-PD-1 and ipilimumab anti-CTLA-4 was shown to be more effective, as you can see in the left panel, although with a much higher rate of adverse effects, as shown in the right panel, compared to nivolumab or ipilimumab alone. This combination was more effective in patients with PD-L1 negative tumors. Then, the role of PD-L1 immunohistochemistry in melanoma is to help the clinician decide between single-agent and combination immunotherapy, not to decide if the patient is eligible for immune checkpoint inhibitor therapy. Thus, in melanoma, tumor PD-L1 expression level may not be a predictive biomarker, but again, it seems that only in tumors with PD-L1 expression level of less than 1%, the benefits of combination therapy are higher than the risks, and in tumors with PD-L1 expression level of 1% or more, the use of nivolumab monotherapy may be preferred over combination therapy. In the evaluation of PD-L1 immunohistochemistry for melanoma, only expression in tumor cells is recorded, which is called tumor proportion score. So a combined score including tumor and lymphocytes or macrophages is not commonly used. Also, only membranous staining is considered as positive. So it is very important to make sure that what we are evaluating are tumor cells. You can see here in these pictures, there are many cells showing membranous expression of PD-L1. However, using a double-stain PD-L1 SOX10, you can see clearly that not all the positive cells are tumor cells. This is striking when evaluating metastatic melanoma to the lung, for example, where alveolar macrophages can show strong positivity for PD-L1 and also nuclear enlargement, and therefore may be confused with melanoma cells positive for PD-L1. A double SOX10 PD-L1 stain in these cases is helpful. Tumor-infiltrating lymphocytes in melanoma are routinely evaluated in primary tumors using the Clark's scoring system that defines them as brisk, non-brisk, or absent. There is a Melanoma Institute of Australia modified TIL scoring that goes from 0 to 3. TILs are independent predictors of melanoma-specific survival, as you can see in the left panel. Some studies have shown association between TILs and sentinel lymph node positivity as an inverse correlation. In metastasis, as shown in the right panel, only intratumoral TILs are scored, while stromal TILs that appear to be important are reserved mostly for research settings. Scoring of TILs in melanoma using algorithms through artificial intelligence have shown prognostic potential. The evaluation of TILs that can be done by H&E manually or digitally may also include peritumoral versus intratumoral compartments and CD8 positive T cell density. As shown in the right panel, CD8 positive TILs at the invasive margin of metastasis predict a response to immune checkpoint inhibitor pembrolizumab better than CD8 positive T cell density within the tumor and better than other markers like CD4, PD1, PD-L1 densities within tumor or at the invasive margin. Finally, the entire tumor microenvironment can be analyzed by multiplex immunofluorescence techniques, for example. This is just to remind us that melanoma is one of the tumors with highest tumor mutational burden, likely caused by high mutagen exposure like UV radiation, and this results in an increased chance of production of neoantigens and enhanced immunogenicity. Indeed, through transcriptomic analysis, melanomas can be classified as high immune with favorable outcome and low immune. In conclusion, biomarker testing of pathology material is an essential component in the clinical management of patients with melanoma, and by adequately requesting and interpreting biomarkers, pathologists play a central role not only in the diagnosis but also in the assessment of prognosis and prediction to response to therapy of patients with melanoma.